Cast is now starting. All attendees are in listen-only mode.
Hello and welcome to the July 2019 Pre-Hospital Care Research Forum Education Research Journal Club podcast. Happy summer to everyone and thanks for spending the time with us in this July month. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. The PCRF partners with the National Association of EMS Educators to promote research literacy and advance the science of EMS educational research. Now here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. I'm Megan Corey and I'm here with Kim McKenna, and joining us in a bit will be Dave Page and Dr. Bill Toon. The study we'll be reviewing today is entitled Use of Cognitive Task Analysis to Understand Decision-Making for Management of Blunt Abdominal Trauma in Children. This was published in a journal called Curious in 2019. Now, Curious is an open access, peer-reviewed medical journal. So check it out online. Thank you all for joining us today, and let's begin. And we want to remind listeners that you can use the chat feature on your screen to type in questions and comments, and we'll bring those into the conversation as we go. All right, a little background. Abdominal trauma is the leading cause of unrecognized fatal injury in children. So training emergency medical professionals on early recognition and appropriate management is essential. Exposure to pediatric patients, we know, is limited, especially for EMS providers and even emergency physicians in certain medical centers where there's low pediatric volume and a lack of specialty care designation. So these authors note that most clinicians will use knowledge from prior experience, information from the medical literature, and I guess we can say protocols might be developed based on that information, courses like ATLS, and advice from experts to guide their clinical decision-making. Experts, though, have naturalized their practice, making it difficult to teach clinical decision-making to the novice learner. So if you're familiar with the Pat Benner's book, From Novice to Expert, that outlines the stages that a person or a student can go through. And this was really focused on nursing. This is several decades ago. I'm sure, Kim, you're familiar with this book. But the Novice to Expert showed that, a student might go through these stages from novice to advanced beginner to competent and then to proficiency and expertise once they have some experience. And so those stages were outlined with particular features that belong to each stage. But it's really difficult to reach on both ends of that spectrum and have an expert teach a novice. Well, there's a technique called cognitive task analysis, or CTA, and this is a method of gleaning the details of expert decision-making by dissecting a specific skill into the critical steps and the thought process that goes into their decisions. So this can then lead to, if you do this CTA, you can then glean these details of what the expert is thinking as they're making these clinical decisions and what they prioritize as they go. That can lead to an educational model then for developing procedural checklists, which we're all familiar with in EMS, right? So these things that we use in novice or initial training programs can be developed from these kind of cognitive task analyses. I thought that was really interesting. So this study in particular is going to aim to use a mixed methods, which was qualitative and quantitative, and we'll go through that in a bit, and use CTA to elicit expert knowledge in the assessment and management of blunt trauma in pediatric patients. And although this is a physician level study, this directly relates to EMS, and you'll see that as we go along here. If you've read this article, and I strongly recommend you read it. It's open access. It's easy to get to. When you read the title, you might say, what the heck? How does this have to do with education? And then read the abstract and then start pouring through it. It's actually, it looks like a really long article, and a lot of it is the details in the tables. So what they did was they used interviews and focus groups in the first phase. They had 2 clinical vignettes to guide the sessions, and we'll go through some of those details in a bit. And then in phase 2, they surveyed a select group of experts from around the country so they could more generalize this knowledge, see if they get sort of similar results if they looked around pediatric trauma experts from around the country. So Kim, you and I were talking before we started here. This CTA has me fascinated. Before we dissect the study, let's dissect this CTA. It has me fascinated. That it made me immediately question. I don't know if Dave's on yet, but immediately question: has this ever been done, or is this done in EMS when we develop this psychomotor competency portfolio for paramedic? You know, in 2015, the National Registry came out with the paramedic psychomotor competency portfolios, thick book of skills, and a great introduction to why we should be doing this. But how did those skills checklists develop, and was any of it part of CTA or used CTA?
Right. Yeah. This is Kim. I was not involved in designing that process, but it sort of seems like it's a similar process that you would use in trying to make a valid psychomotor exam, where you're trying to decide what are the steps that are essential to have a successful outcome. And so a lot of times that is done sort of in the same way that these folks did it, with some expert consensus, you know, like when the National Registry brings in people to develop skill rubrics or even to develop test questions. They look at that foundational knowledge from the literature like these folks did, and then they also get the expert consensus of what are the essential steps, and that's sort of how they come to, part of how they come to validity in their testing instruments. And yeah, so again, I don't know the specific steps of how the portfolio was developed, but this is, yeah, I agree, this is really an interesting study.
Yeah, and I don't know if once Dave comes on, but we'd like to, we can return to that. But I think also it's not just National Registry too. Individual programs develop their own check sheets, and you know, there's educators out there on the line. If you have a certain method that you use to develop your check sheets, I would imagine, like you said, that it's a lot of it is consensus building. It's you know, several experienced providers in your area or experienced educators dissecting a clinical skill sheet that maybe was developed by, you know, it's in a publisher's you know, textbook or the National Registry, and deciding to tailor it because of, you know, for whatever reason they didn't like the order or the detail or whatever. And we'll talk about that a little later. The order of things, I think, is another issue that we have, and something that comes up in this study. So we'll return to that discussion. I think it's a really good one, because when we talk about what they did with this, we can, you know, relate it to EMS. So this was a qualitative and quantitative, that's a mixed methodology. And in phase one, the qualitative phase, this was a focus groups and interviews. And the focus groups, these were 7 local experts. So this is a trauma center, regional trauma, pediatric regional trauma center, I should say. That's a very important distinction. So these are semi-structured interviews that they did. It was recruits from a pediatric regional trauma center. So there were 7 local experts, 4 were pediatric emergency medicine specialists, and 2 pediatric trauma surgeons, and 1 fellow who had prior experience as a surgeon. But the expertise, how did they define them as experts? I thought that was a very important aspect of this, because if we're going to base this on expertise, we need to know, what did they say, you know, how did they define this expert level? It can't just be that you're a trauma surgeon. They wanted, you know, more detail about this. So board certified, and they had to be board certified either as attendings in pediatric emergency medicine or as surgeons, pediatric trauma surgeons with greater than 5 years of experience in the management of pediatric blunt abdominal trauma, which is what they looked at here. Experience as a trauma team leader. And this was the part I thought was really great, they also had to be involved in graduate medical education. You know, and I thought that was great. And many of them were preceptors, some were, you know, directors of fellowship programs or of medical education programs, and involved as at national or local levels in trauma committees. So I really, the thing that stood out to me was that they also made sure that these experts were educators. And I think that, you know, maybe it doesn't, but I think that probably would make a difference, because they're familiar with the common, as they call them, novice traps, and familiar with others. So
I thought it was probably a real challenge to organize this when you think about it, because the initial interviews of these clearly really busy people were like an hour and a half per person, and then they brought them back for that phase 2 for another hour and a half. So just the scheduling and the logistics of it, you can imagine as trying to organize this would have been really challenging with this kind of a group of people.
Yeah, for sure. And if anybody out there is familiar with qualitative research using things like document review and interviews and focus groups to pull out themes and sub-themes in this case, and from the narrative. So rather than quantitative research where we're trying to actually look at things in terms of numbers. So they used also a tool that I don't think I'm familiar with. It's a criteria for reporting qualitative research guidelines. I've heard of the other one, the Mirsky. This one's the COREC. And this is to kind of do a self-check on their techniques for qualitative studies. So it's always good to have something to measure your methodology and make sure that you're using kind of best practices when you're performing a qualitative study. So their interviews, like you said, 1.5 hours each and an hour and a half each, and they were audio taped and then transcribed. That alone is a lot of work. And then they had a panel of them, of the group. And now, why do that? That's the other thing that we discuss when you're deciding on a methodology. So you can have, why not just stop with the interviews and why have a focus group? But as they point out, they did the interviews first and interviewed separately because they wanted to not get that, and they called it premature consensus building. That is the disadvantage of the focus group. Well, there's just a couple disadvantages of a focus group, advantages and disadvantages. So you interview people individually, you get that kind of pure, you can call it kind of purity because you have an individual. But the disadvantage of an individual interview is if you have that person with a few other people in the room, the individual might think of something that someone else thought of and they say, oh, you know what, I agree with that. That's really important. And so you don't get that consensus building. Then when you get a focus group, you get consensus building, but the disadvantage might be you get one voice louder than the other, or someone may not be, they may be reticent to speak up about something. So you may not get those individuals. So I really like the way they did this. They did the individual interviews first, and then they did the group. And again, it must have been just a bear to try and schedule these folks all together. And then they used some guidance. I mean, it wasn't just, well, we'll use a bunch of open-ended questions. They actually used some guiding documents. One was they used information from an ATLS course so they could guide, what are the key kind of features of that should be in this treatment. So they'd ping the group about, more specifically, and there's a lot of information in this paper about that. The other is they used 2 clinical vignettes. So they had 2 actual case studies that they used to kind of guide the discussion to gain insight into their internal thought process when they're managing a patient. And then they tried to do it where, they didn't just hand them a case study. They fed them information as it went along to kind of mimic that that dynamic nature of the call itself as you gather information. And, I know that we should do that really with our students in the classroom too, handing them a full-on case study with all the answers and everything, except for the outcome, turns them into diagnosticians. Oh, let's do this, mystery diagnosis, rather than, problem solvers, actually seeking out the information. So I thought that was great the way they did that. And then they also...
I'm sorry, Megan, I thought the fact that they had the 2 cases that were sort of patients that were arriving simultaneously sort of really increased the depth of knowledge that they could extract, because that required prioritization and, sort of managing multiple priorities. So I thought that was really kind of a clever thing that they did there.
Yeah, that was. I wonder what made that. I guess they were trying to mimic the actual environment. You're going to have to arrive at once. You're going to have to prioritize one over the next, or certain things first, procedures first. And then the other thing they did was they asked, using open-ended questions, to more of the educational aspects, the critical decision points, potential errors and novice traps, helpful sensory cues, which I thought was very interesting, like what kind of things, you know, we don't usually put that in a skills sheet. You know, what kind of things are you looking for? Although I guess you could say situational awareness is similar. Necessary knowledge and skills, and then quality indicators. So they had all of these types of, and this is the phase 1 themes that you can see that came out of the study. But basically they pinged them in these areas. So the other thing I thought was really cool, Kim, was that they, the researcher had some type of training. I mean, it sounds like it's obvious that you would do this, but they had training in how to perform cognitive task analysis by an instructional designer or educational researcher. So someone who has done this before. So, and that made me fascinated, like, where do you find this sort of training in cognitive task analysis?
Yeah, that's what I was thinking too, but you know, maybe it's that person that can say, okay, you have to have 2 cases that are happening simultaneously if you want to learn about this dimension and this dimension. So yeah, I'm wondering where they did have access to it. I'm thinking that this study happened in Kansas City because that's where the researchers are based, and that's pretty close to me. I'd love to talk to that person and understand how you do that.
I'm glad you said that, because I just want our listeners to know we typically reach out to authors, and you know, these are busy people, not everybody is able to join us, but we always make a good faith effort to reach out to the authors by email and invite them to join us and tell them that we're going to be reviewing their research. So commonly we get enthusiastic yes responses, and sometimes we get them after the fact saying, oh, I'm so sorry I missed your email, I would have loved to have joined you. So we always try to get that in here. But yeah, it's pretty cool. I think it would be great if you were able to get in contact with them. Okay, so let's look at then the second phase was the external expert survey. So what did they do with the first 2, with the interviews and focus groups? Well, that's where the real work of qualitative research, if you've ever done this, really goes in. You transcribe, and then I want to, just shatter a myth out there that you just plug qualitative data into this in vivo program or one of the qualitative, I will call them organizers, basically, programs, and out shoots your themes. That's really not the case. There's a lot of work that goes on, and it's mostly on the part of the researcher. Programs like In Vivo and others that will help you with, glean your themes and sub-themes or categories out of the descriptive data or out of the narrative data are extremely helpful to organize large volumes. So I'm certainly not saying they're not helpful, but there's a lot more work that goes into it than people think. It's not just like a statistical program. You don't usually just plug things into StatView or into one of the statistics programs and out comes your answer. So it helps to know how to use those and go through some tutorials and instruction, have somebody who's nearby who's a statistician or a qualitative researcher to help you figure this out. So when you're doing this, the themes then emerge from here, and here are the themes that came out. This is the themes that help them create now a framework and how to code their data. So clinical management, clinical reasoning, situational awareness, and situational awareness fascinated me a little bit because situational awareness is very different from the trauma perspective, trauma surgeon perspective, than it is from the EMS perspective. It's the same, but in terms of the patient aspects, but we always think situational awareness like everything else around the patient, the environment and what you have to deal with. And so you can add that on as an EMS provider. And then the ones I highlighted here, potential errors and novice traps, knowledge and skills, communications and teamwork, and quality indicators. These were all things that I thought we'd highlight in this discussion because they really relate to some of the things that we see in education. And as you noted, Kim, some of the findings were extremely similar to what we see in EMS.
Yeah, as I looked at their results, I was like, oh my gosh, so much of this is what we teach beginning in EMT and then certainly expand on greatly in paramedic, and then we're continuing to work on with our paramedics that are on the road right now.
Yeah, exactly. Oh, and continuing education. That's a really good point. I'm always talking about initial education. It goes on, right? We're always a learner. And I did sort of skip over something. I mentioned the phase 2 and didn't go into it. So the data that are showing and the themes that you're seeing, and actually when we go back, the themes that you're seeing are from both, these are the phase 1 themes. What happens in phase 2 then is the researchers wanted to then expand to see, you're looking in phase 1 at just the local experts. So that can be influenced by your local protocols or policies or practices or culture in the area. And to see, whether this, to kind of double check, or what we call in qualitative research, triangulation, to triangulate, it really strengthens your reliability of your study, and really the validity of the data that and the themes that come out. And then the reliability, because you're actually able to generalize it to other areas. So in phase 2, what they did was they surveyed the select participants. So they selected and recruited 11 pediatric emergency medicine attendings and 11 pediatric trauma experts. And they did this by email. So they contacted them by email, sent them a reminder. They could have had 22, but we never get 100% on these, or rarely get 100% response. So they had an N of 17 on this. So 17 experts, and they surveyed them about, they had a structured survey about the same things that came out of this qualitative, to double check the themes and the results from the first part. So let's look at these sub themes. And again, I chose just the last 4 to look at in depth, but if we look at the actual first few of these, the sub-themes for clinical management and clinical reasoning, which are in the paper, and situational awareness, the first 3, like you said, Kim, it looks exactly like you would, with the exception of things like, well, even the FAST exam now in some places is done, but with the exception of imaging and certain lab values, everything else, crystalloids, primary, this is an order of frequency. So crystalloid fluids, primary and survey, secondary survey, reevaluating the patient, pain management, performing a FAST, disposition, IV access, blood products, revise your management based on change or new data, forming your goals, co-managing multiple patients, and remaining vigilant. So these all look very familiar to us. So, and then
if you're thinking about like the out of hospital exam and how that's structured, and these are all skills, again, without some of the advanced diagnostics that a person has to be able to do that at the paramedic level, because they're going to introduce a change, so you have to be able to revise your plan, you have to maintain awareness, and the only, few exceptions, you're not going to co-manage multiple patients in those scenarios, but it is so relatable to EMS.
I did find it interesting, though, that crystalloid fluids was the most frequently cited sub-theme for clinical management before primary, secondary, reevaluating the patients. And I think a lot of that has to do with that expert thinking. I had a student one time say to me, I just can't, I can't understand how my preceptor walks into a room, touches a guy in the stomach, and says pancreatitis to me. And I said, they're putting together everything in a very rapid fashion, or they've met this patient before, one of the two. So I said
I wonder if that sort of ranked high, just because that's something when they get patients referred in from tertiary centers, from rural centers and that sort of thing, that's a frequently omitted thing on children with abdominal trauma, that people are too hesitant to do that, and that's where kids run into trouble. So maybe that's why that sort of rose to the top there.
Yeah, that's an interesting point. One of the other sub-themes that's in here is clinical reasoning, and the 4 sub-themes were order imaging, and this is in order of in order of frequency. Order imaging, consider hypothesis, review and interpret data, and order relevant tests. So again, very physician-oriented because you have imaging, but the hypothesis and the review and interpret data, I would say, is really at all levels, just a kind of maybe not so much the hypothesis, but reviewing and interpreting data and other relevant tests were themes. And then situational awareness was interesting. So this is where I say, you know, it would be very interesting to do the same thing and ask EMS providers what, you know, situational awareness. We would want to know, well, what was the trauma? Was it a vehicle accident? Was it and so the clinical vignette, the information, the situation, the context of where we're finding the person matters. And I go through this with students sometimes when it's why we give them, before they arrive in a simulation, where they are. Okay, you're in the basement apartment, you know, we tell them, you know, access kind of things, or we put it into a realistic area where they do see the access that they have, so they know, okay, that will matter in where I'm going to treat the patient. Am I going to start it here? Am I going to do it there? Am I going to, you know, at what point, well, how far am I from a hospital? You know, at which point am I going to treat this patient? So in this sub-themes for situational awareness, their number one was trauma activation or consult, and then gathering the information, anticipating the next step, triaging patients, assessing the situation, prioritizing tasks, using sensory cues, maintaining a big picture, and remaining vigilant. So again, all of it having to do with the flow of a patient, less so with the context. So don't you think that, Kim, when you read that? I mean, I thought for sure this would be the area that would look the most different had these been EMS providers.
Yeah, I agree. And when they get into the detail, then later they talk about some of the things in situation. Well, it's part of the sensory cues including things like how nervous did the paramedic or anxious did the EMS provider sound when they gave the radio report? Did I hear sirens, meaning that they're running code versus running without lights and sirens? So yeah, that was really interesting to me too.
I think that's a really interesting point. Oh, yeah. Dave, you're here.
Hi. Yeah. Hey. I'm actually delighted just listening to you guys because you're so smart, and it's very interesting to kind of see your thoughts. But I did think that the fact that prioritizing tasks and communication fell to the very bottom with significant in the potential errors for situational awareness was not typical of perhaps my experience with evaluating and simulation-based evaluation of paramedic students. I often think that lack of communication and lack of the correct prioritization, people are doing one thing or another and not doing the most important thing, is actually more, I would expect it to be at the top. And so I do think that this, like you said, if part of the problem is that the initial trauma team activation or consult is part of their top frequent situational awareness element, seems like it would be very different if this was done for a set of paramedic students or EMS providers in general.
Yeah, I would agree. And just looking at this here, the potential, actually, this was my favorite one, though, the sub-themes for potential errors and novice traps, because, well, maybe because I teach initial training of paramedic students, but this is physicians, and we're seeing the potential errors and novice traps, tunnel vision, incomplete physical exam, maintaining the big picture, recognizing shock, and then all of these others: omission bias, coordinating team activities, missing sensory cues, communication, prioritizing tasks. So yeah, I think it's strikingly similar when you look at the errors and novice traps to any level of emergency provider.
It's funny here because the maintaining the big picture rises to the top here, where in the situational awareness it was lower. So I guess they're sort of thinking the experts that's less likely to happen.
Exactly.
But for the novice, that is totally something that you can see in the sim lab when you have your entry-level students particularly.
Yeah, for
you
sure.
can see them sort of falling into these traps really easily.
This gives us a good roadmap on the kinds of things that, based on evidence, we can focus on with EMS students. And they may not be 100% the same, but the themes seem to be very compatible. So, you lose your big picture, you get tunnel vision, you're not recognizing the patient is in shock. These are classic errors in patient care that, we bring them out in simulation, but they exist in real patient care as well.
Yeah, and the incomplete physical exam, I have a faculty member here that's definitely his pet peeve, who's that students are not consistently completing their physical exam on all their patients. So I think we have Bill Toon here. Is Bill available?
I'm here. Can you hear me?
Yes. Have you been listening in?
Not as long as I wanted to. The workout ran later than I thought. So my heart rate, though, is at least under 150 now. So
Yeah. So we're dissecting this study on cognitive task analysis, which dissects an expert performing a skill or performing actually more than just an isolated skill, their clinical decision making while they're dissecting how they would perform with a pediatric critical abdominal trauma patient. So, and talking about how this relates to EMS. Earlier I had asked Kim, is this done? Has this ever been done in EMS? When we developed the psychomotor competency portfolio, was it more of an expert panel that said, yeah, this is what the order of steps should be, or this is how this should be the steps, whether they're in order or not? Or did anyone, has this ever been used to your knowledge, Dave or Bill?
Yeah, I think that, so the National Registry develops their task and the order in which you do these tasks in expert panels. And so there are various methodologies and as to how you can develop these cognitive task analysis. And some of them are, applied cognitive task analysis where it's more of an applied method, a critical decision-making method, a skill-based method or a framework, task knowledge structures method, and a cognitive function model. So there are different ways to develop these types of lists and then to analyze the types of errors. And I think sometimes the expert panels don't really need to know exactly what method they're using, like the participants in the study. They're just asked to list all the tasks that need to occur. Mm-hmm. It's also a curious thing to spend time trying to validate a single scenario. I think we did 33 workshops teaching the entire nation, for EMS instructors how to do it, and it was just kind of an awareness exposure to the process, but not really we were going to complete and fully validate a scenario, because it is listing every variation or the variables that you at least insert in the scenario affects the number of tasks and the cognitive ability. So the distractions, the consequence of each one of these actions. And like Kim McKenna, I'm going to go find a course that actually formally teaches you how to analyze this, because I'm fascinated by the thematic rank ordering, but also the concept that perhaps this needs to be done for every scenario in a high stakes exam, because unlike our practice scenarios, the high stakes exam could really be a significantly more difficult exam depending on the cognitive task or the load that is expected from one case or another. And we've done a podcast on cognitive load and how quickly you can get to saturation. So either the post analysis or in progress analysis as you're shaping these is clearly going to affect how people, how an expert or a novice can perform.
So I have a question in here. So do we teach patient assessment thoroughly enough in the initial programs, and does that play into the ability for them by the end? What I mean by that is that I was a victim of Barbara Bates's guide to physical assessment.
Interesting choice of words. The victim.
Yeah, but it's my favorite book still on my bookshelves.
Yeah.
And when I want to go back to something, or I want to hold another clinician to something, I go back to that as my reference. It says, why did you do it that way? Because I don't think you can do what I always said to students when I was trying to teach them is I want to teach you the long way of doing division versus the shortcut. You can do the shortcut only after you've mastered long division. And I think that's something that I think that we sometimes move to focused exams and shortcuts before they're competent in that very thorough exam. Just a bias that I have, and I don't know if anyone else has a similar or see a similar experience, because I see it when I actually watch other people practice. One advantage is still working in the field to see how people practice.
So, I'll let me see if I can push back a little, play devil's advocate. But because it is a kind of a divergent thinking concept versus a convergent, or are you looking so specifically at one disease or just seeking out one particular problem, and then you have confirmation bias and all the other ills that come from I was just looking for this, so I missed this other thing, versus also knowing that with science and enough exposure to certain cases, we know that when these three things are in place, it doesn't matter what the rest of the story is. You need to kind of move on it. So let me just again continue with the concept of a STEMI. The concept that there's 1 millimeter of ST elevation more than in 2 contiguous leads. You can have an entire differential diagnosis on chest pain, but if you find the STEMI, then maybe there's other things going on too. But that is you should actually be able to drill down to that fairly quickly. Otherwise, you could do a Barbara Bates style full physical exam, but it's really that text was meant for a normal physical exam. And we're in the business of this is going to kill you right now, and you better find it quickly. And you're not going to have time to do this conceptual, full theoretical assessment. We're gonna sort of do a heuristic, matching of these things will kill you. So I'm gonna make sure that these three things are out of the way. And then later on, if somebody else wants to go and try and figure out what the zebra is, or what the very the thing that's possibly the answer but isn't going to kill you right now is really the problem. So I agree with you that perhaps we teach differently, and I agree that the differential diagnosis has been maligned in EMS education, so that we keep falling back on don't think just you're a technician, you just if these symptoms, then this is the answer, which we do need more heuristic and critical thinking. But I don't know if we need the traditional depth of assessment that we have. I think I heard Greg Margolis say this once. We have extreme depth in a vertical environment. So the rest of healthcare might have extreme base. They have a lot of knowledge on things that are diseases and problems that are long term, whereas we have this profound, very rapid and important depth in, say, for example, EKG interpretation and lethal rhythms. But if it doesn't, it's not going to kill you right now. The paramedic is the wrong instrument to send to that disease or that illness or that patient.
So I agree, Dave. How do we develop where I see this is if it's clear cut, like you're saying there, they have those 2 or 3 things and they don't miss them and they move on them, I agree. But when the person doesn't have those and isn't immediately life-threatening, that's when I see that paramedics struggle and they lack the ability to tease out what's possibly going on. And I think this is what makes us, in our current model, a poor community health worker.
I totally agree. And yet we were designed, our DNA, we were bred for the attention to a patient who is going to die right now. We were not designed or bred or trained or educated to care for a long-term health concern. And when we do call up the community health worker, community paramedic, mobile integrated health role, then we see our tremendous lack of ability and lack of understanding of some simple stupid stuff like in a disaster everybody needs water. They just need potable water. Because we're bred for no, we don't really care about salmonella. We're gonna focus on this. And I do think, I'll again play devil's advocate here. I don't know that I believe my own stance, but if you start to go in the direction of community paramedic and mobile integrated health, where does it stop? I mean, what we are abandoning our traditional role, and it's actually through and we're discussing this paper, so let's not get up too far. This paper does a really good job of saying if we're going to really be good at a pediatric abdominal trauma, where are the pearls and pitfalls? Where do the novices and where are the experts, sort of how to analyze that? And when we start straying into all of medicine, then I think we lose that very razor sharp ability and time and effort to get really good at, this is going to kill you right now, and we're going to really be good at figuring out it's this, or maybe we don't know what it is, but we are going to make sure that you don't die because we didn't ventilate you, because we didn't treat the shock regardless of the cause.
Yeah, this is a really interesting discussion because I think you see very different things at the EMT initial training level than you do at the paramedic initial training level. You see the EMT, we automatically get them into that streamline, here's your assessment, march through your assessment from, scene size up and BSI and everything all the way through. And then they get to paramedic and we slow them down with the comprehensive pediatric physical exam that's 8 pages long and looks at hair and fingernails. And that's when you really start to get instructors and students that start to say, okay, what is this about, this comprehensive exam? I don't see this. I'm from the BSI scene safety thing, and now you're coming into this and you're telling me I need to do this. So I think it's that a lot of instructors struggle with that piece of it. Let's return to this here at these last few themes and see what they developed out of this too. Speaking of long and detailed things. So we have the sub-themes for knowledge and skills. Notice experience, training, and protocols are right at the top. I would not have thought of experience at the top of knowledge and skills, only because but thinking about that these are experts that are answering this, like Kim alluded to earlier, that they're valuing that ability to draw on their experience and say this is what it is. But training and protocols are right up there as well as physical exam. And then less so on algorithms, which is interesting because you have protocols and you have algorithms, distinct, very distinct there. So I thought that was interesting. Desire to improve, so an affective thing, and then procedural skills. And then the other two sub-themes that were very interesting for communication and teamwork. You have several things in here that directly relate to what we're trying to get at in paramedic education, I know, with coordinating their team activities and exchanging information, closed loop communication, that kind of thing. I think one of the things that initial students struggle with, at least from my experience, has been the ability to verbalize your plan as you go so your team knows where we're headed. Don't just do things what's right in front of you. I'm going to do this, and I'm going to do this, and we're going to do this. We've got to verbalize the plan, and that can actually lead to the next thing, which is speed. So sub-theme for quality, notice speed is up there as number one.
Don't you think, though, going back to that communication and teamwork, doesn't this look like, what does this sound like? It sounds like crew resource management. I just
all the way.
Yes.
All the way. This is
yeah.
CRM in its raw and pure form. This is the kind of work that needs to be done in our industry for every single possible process. This is the kind of stuff that aviation did for every single process. So, when we look at how, what happens when a windshield gets cracked at 40,000 feet, there needed to be somebody sitting there going, okay, let's break it down. This is where the novices, where the experts are going to fall. How are we going to make sure that they respond appropriately? And this is the beginning, I believe. Now it's obviously the beginning in healthcare, not in EMS or pre-hospital. But we need to do this work pre-hospitally to realize what is or isn't important and what goes into a checklist. Because our checklists really are just one size fits all, and this is starting to tell us, speed, smoothness in this particular case is important, and in another case it might not be. And the CRM slow is smooth is fast. People may go faster if they're actually following the checklist than if they just try and do all of these things and they're all floating in their head.
Mm-hmm.
You can't have the checklist until you analyze these tasks, and that's why a cognitive task analysis is critical.
I love the trust too at the end there. That's an interesting one.
Yeah.
I think that would come out in experienced providers more than initial providers. I think it would be very interesting to do this very same thing with your initial novices and compare them to your preceptors. It would be great to have some level of that before an internship, an analysis of the novice to a certain level of detail, and then analysis of the preceptor, and see what comes out. Because I know the experienced folks, trust is a big deal. You're dealing with different responders all the time. If you're in an area where you don't necessarily know your first responders, and your first responders don't necessarily know their transport providers and multiple agencies and all of those things, trust becomes a factor.
Mm-hmm.
Well, and isn't it true that it cuts both ways? If you trust too much, right? So, sorry, this is the old dog in me that says, oh yeah, I delegated the airway to the first responder, and that happens to be a novice or an expert who, perhaps isn't focused on the rate of ventilation. And suddenly I look over and it was delegated. I didn't even think about it. And we had these conversations when we were working on grading and figuring out what was pass or fail on the National Registry exam. If your partner is simply, you've delegated a task and your partner is doing it badly, are you still responsible? And so the team leader really, that sort of step back, look at everything that's going on, and say, it might not be malicious. It's just that there's a lot of distractions, and not so sure you can trust everybody to do exactly what you're asking them to do correctly. And then there's closed loop communication verifying that you're actually doing it right. So very interesting, the concept of trust.
Right. Well, it's that old trust but verify. You just said both of those things. As a team leader, you've got to do both.
Mm-hmm. Yeah, and if you think you're going to do it all, then you're clearly, that's incorrect. So, yeah.
So this is the phase 2 part of the study. What you're seeing is the quantitative aspect. So the categorical data were grouped, and there was a ranking system based upon these pre-arrival steps. So the expert review survey was designed to verify the information that came out of the interviews and focus groups. And they didn't say too much about where they were, where they pulled the experts from, but they did select from a variety of areas. They said it was a diverse demographic or diverse regions, and selected 17, well, 22, but they ended up with 17 external experts, they called them. And so they had them rank these pre-arrival steps. This is the frequency table that you're seeing. And up at the top, upon EMS call, determine if the child is sick, based on vital signs, mechanism, obvious injury. So that's a nice little message also to us that the mechanism, injury, vitals, and treatment is the MIVT report is used and is also ranked as the first thing that is the most important. And then we see activating the trauma team, establishing a team leader and assigning roles, communicating the requirements for staff, equipment, resuscitation, obtaining information from transport about the mechanism, and that I'm assuming that might be a interfacility as well. And then estimating the weight of the patient, also a piece of that. So this was the quantitative data that actually helped verify what they found from the local data. And then finally what they did, and this is over several pages, so I took one piece of this to show. They developed, and this is probably the thing that might generate the most interest here, is they developed a comprehensive decision-making tool based upon this information. So they used these, and here I just showed the very first line of the first 5 minutes table. They had tables and subtables that were on, the first 5 minutes of care and then subsequent care. And the management step, the assessment, what you decide, what you avoid, and how to improve. And I just thought this was a very interesting table with a lot of detail. The utility of it, it's not designed, I think, to just pick up and use, while you have this critical pediatric patient in front of you, but I think there are elements of it that that you could, maybe abbreviate into a table or a protocol or an algorithm, and then but each one of these elements is gleaned from the data. What did you guys think of this?
Again, this is Kim, it goes back to the fact that almost all of the things in these, their conclusions relate directly to what we're teaching in EMS. And I think it sort of goes back to, first of all, some of the disputes we have, because there wasn't complete consensus on everything. And sometimes—
Sorry, I think I lost you, Kim.
Oh, sorry.
I can still hear you. Kim, yeah, I can still hear you.
Okay.
I think
Yeah.
Kim was saying, we were talking about it earlier, is that a lot of what they've done relates directly to EMS. So it looks very, very similar to what we do in EMS.
Okay, Megan, can you hear me?
I'm sorry, I thought maybe I lost you for a minute. Yep.
Because I think Kim's point is spot on, and I think when you're going to the result of this, in terms of having a list of things to avoid, a list of things to improve, what needs to be decided, what needs to be assessed, to me zeroes in on that. These are the elements that then can create those very, very important checklists that are very specific to these kinds of problems. And I also love that they chose abdominal trauma, the abdomen being the sort of black hole of diagnosis and despair, because it is one of those complaints that can be very difficult to pinpoint. And when you break it down into first 5 minutes of care and then the next 10 minutes of care, you now have a beautiful grading rubric for critical criteria in a scenario. So it was, I think that's just, ideal and what we should be doing for every one of the simulations that we use in a high stakes exam.
Yeah, I agree. Bill Toon, do you have any feedback on this comprehensive table, this decision-making tool?
I need to spend more time with it.
Yeah.
There was, as you said, there was a thickness to this entire thing, but I liked what Dave just, I have to be careful, I liked what Dave just said.
Oh, no.
Oh,
Don't
no.
Bill.
Wow.
That is, our listeners might actually get used to some I don't know,
if you're interested in this, there's a broader paper that was done in 2011 by Jan Jensen, Dr. Foskary, and Dr. Travers, and it was a Delphi document, and they identified 42 critical decisions that an EMS provider has to be able to make. And so
I didn't catch that.
Just as just something else.
Siri wants to know that too.
Yeah, I know. Gosh, I didn't know how I did that. But anyway.
I didn't catch that. We can share that paper, and I think you're right. It's that's wonderful.
Yeah, getting to the study too, I think it's really important to notice that there were discrepancies in some of the expert opinion. And most of them, though, had to do with imaging. And I thought that was interesting. That is it because imaging, there's been an over-reliance on imaging? Is it because some of the imaging is relatively new? But there was definite disagreement on the importance of the FAST or the relevance of it in deciding in a critical pediatric patient. So I'd be curious to see how that would pan out in EMS. But it's important to know there wasn't universal agreement on everything, and those little areas of discrepancy, that was an interesting part of the paper. Imaging studies, specifically the timing of chest x-ray and the FAST exam and the use of pelvic x-rays. There was some discrepancies and disagreements among them. So about 30% of them thought that the FAST exam is not helpful in the disposition of a patient. So I don't know, that kind of stood out to me. There was also, let's see, additional potential errors that the expert noticed: lack of identifying a team leader, poor crowd control, a failure to revise or summarize or perform serial exams, and then over-ordering or over-relying on tests and over-testing due to liability concerns, which I thought was an interesting one too, and that might be something that pans out in the field as well, overdoing certain things like spinal immobilization due to liability concerns. Poor consultant-to-consultant interactions and delays in definitive care and lack of ownership. I thought those were another list of additional potential errors that they commented on.
Boy, that strikes to the core and the heart of our current decision-making process, right? I mean, we're just going to throw people on backboards because that's what we always did, and that's what's going to make sure that we don't get in trouble and we don't get sued. And we're going to, put people on oxygen because, that's just, good patient care. Just everybody gets it because that way, at least we've done the basics. When a paper really can get to the heart of the matter and just love the, and I love the exposure to the concept, but I'm also real skeptical and sad that it takes, decades for research to be reconfirmed for people to believe it and start to change. And maybe that won't be the case with simulation research, but I'm super happy that you picked this paper because it really is to the core getting at EMS education issues that we need to be paying attention to. And this is the kind of homework we should be doing with every one of our tasks.
I agree. They also note in the end of their paper that the future studies should involve researching the efficacy of this kind of a tool, like you mentioned, and teaching in a randomized trial or testing the validity of this kind of a tool. And we could do that now with testing the validity of tools that we already have using this. And then the interesting line at the very end that I had to almost laugh about because it sort of came out of nowhere is it said, our findings might be utilized as a blueprint for serious video gaming, which made me immediately.
Yeah.
Oh, that is actually quite so there's a whole culture around game theory being part of this kind of new wave of virtual reality medical education. And ironically, it might be that kind of sort of commercially driven, funded, and heuristic type of research that's needed for the game theory could help us in real life. I really enjoyed that part. I thought, it's I know you were laughing, but man, that's scary how, in fact, that would help us quite a bit. Actually.
It just sort of came out of nowhere because it wasn't mentioned earlier in the paper, and of course it made me think of Bill Toon, who I know is a serious gamer out there.
Yes, I am.
Okay, well, we're at the top of the hour, so thanks so much for everybody joining us. Dave, any final thoughts from anyone? All right, we're going to end with the image of Bill Toon as a serious video gamer. So thank you all for joining us. Next month we'll be around again. And remember, Monday, August 12th, 2019, we'll be here for the clinical podcast. And Friday, August 23rd, the Education Research Journal Club podcast, 10 a.m. Pacific, noon Central. If you want to present an upcoming article, please email David Page at dpage@emsed.net. That's dpage@emsed.net. Thanks for joining us. See you next time.